with Rishi Singh, who's from the Cleveland Clinic, and we're joined here at the Retina World Congress in Fort Lauderdale, where Rishi just gave a fantastic presentation on GA, some of the imaging modalities. Rishi, thanks so much for joining us and for speaking with us.
Thanks for having me.
So I guess we'll just jump right in. So we spoke a little bit in the session about, GA and the imaging modalities that we kind of use, and you broke it down really well to talk about a bunch. Could you give an example of how you kind of go through patients and the kind of imaging modality and protocol you use?
Yeah, so I think we've always relied on fundus photography, and that's a good biomarker for a lot of the diseases we take care of. Quite honestly, it's not enough quantification, there's not enough contrast in those images we're getting. So we now have relied, especially in looking at the pocket gave on geography, on things like OCT-based transillumination effects, as well as looking at things that are quantified in fundus autofluorescence, which we can do now. OCT-based criteria have been just equally as good as fundus autofluorescence, so I typically use my OCT for those measurements. And now with AI, all this AI plethora of things that are growing, we're seeing all this ability to automate these measurements, both the photoreceptors as well as RPE loss. It's been a great way of looking at these images much more quicker and faster in practice.
You mentioned FPF, the flavoprotein. I've actually looked into that a little bit. I'm doing a little bit of research on it. Can you talk a little bit more about that and FLEO and just looking at some of the measures and a little bit more about the fluorescence?
Yeah, fundus autofluorescence is just a broad category, and really what we're looking at is these fluorophores which exist within the retina. They can be on the retinal ganglion cells, they can be in the RPE, they can even be in the lens capsule or the anterior segment of the eye. So we have to first be able to block out all of the other fluorophores to look specifically at a specific fluorophore, for example. In flavoprotein fluorescence, we're looking at that particular fluorophore, which is associated with mitochondrial dysfunction. We all know that mitochondrial dysfunction goes along with aging of the eye, and there's the diabetic retinopathy, there's all these progressions. And as part of that, we can monitor that and follow that over time. What FLEO is really the fluorescence lifetime imaging of the eye. So looking at the fluorophores and looking at their density and changes and their different parameters as they go. So again, looks at a broader picture of those sort of things. And then we have fundus autofluorescence, which really is lipofuscin, which is what we're looking at in the retinal pigment epithelial cells. But again, we have to make sure that we get out all of the other things that would be in that excitation emission range. Really look specifically at lipofuscin because it can have a broad range, and therefore it can have a lot of inherent sort of issues.
And some of these fluorophores, do you think that they might show subtle differences before it comes up and shows up on UCT? And should we be using them more in clinical trials and studies?
That's been the genesis of a lot of my research work, because I think that FPF is one of those ones where we looked at, for example, some of the diversity of the images and seeing changes before and preceding vision improvement and neovascularization and for diabetic retinopathy and diabetic macular edema. So yes, I think it's a early biomarker we're following. We're looking to see if it could be better in prediction of potential visual improvement. You've knocked down those fluorophores, you've improved the overall retinal metabolic state, and therefore, then you're seeing the after effect, which is the functional change in vision, which is what we hope to see in these things.
Yeah, I think with some of these diseases, it's good to kind of see which ones will have VA changes kind of earlier versus later. And I think GA is one of those where the vision's going to be kind of at the end. And so you do want to look at some of these subtle differences earlier.
Yeah, and it's a tough one because I think that, again, we don't have really good correlation with vision and geographic atrophy. There's a lot of differences there. And so we're just trying our best to look at other alternative mechanisms like this one and others that are out there to look at those differences overall.
Nice. And now, we're lucky enough to now have treatments that we've actually used with patients. Yeah. Have you started noticing some of these differences with patients that you're injecting? I know the US has the most experience.
It's funny. Anecdotally, patients do say they see better. I'm not sure if that correlates with anything, but there's a lot of patients after the injection say, I see a little bit better for that reason. Again, there's always a placebo effect. You can't quantify that measurement, but it's certainly something that they're committing and saying to, which I think is quite interesting to watch.
I think you mentioned also that there might be changes in contrast. So maybe that's something that they're seeing.
Yeah, no doubt. I mean, I think we have to look at all those measurements, but right now those patients have had a significant effect that we've seen in any of the studies we've done and so on and so forth, and really are not seeing that effect but maybe these studies are too small, and maybe they're not long enough, right?
Yeah.
We're going to have the Gale study, which was 3 years of extension data, to a 2-year study, so 5 years of data total, which should help us quantify sort of that outcome.
And then you mentioned one of the side effects. I know IOI is always an issue with injections, but you mentioned kind of the neovascularization that might happen. Is that something that if it does happen, like what's your kind of treatment algorithm?
Yeah.
How you kind of deal with that?
Yeah, this is one where we know it's sort of a class effect with complement inhibitors. And what I've been basically doing for those patients, and I've only had, again, a handful, but we've essentially kept them in treatment with the anti-complement drug plus add the anti-VEGF. Now, again, sometimes we may say that the patient will say that's too many things I want to do, or I don't want to come in that often, so we then have to cut that down.
Yeah.
But for the most part, patients are very, very happy to have both treatments and know that there's a reduction in the progression, but also a potential benefit as far as the anti-VEGF and improving the vision.
Yeah, that's fantastic. Thank you so much for speaking to us at the Retina World Congress. Tune in for more episodes where we get physicians from all over the world.
clinicianlink.ai